You're welcome to my channel. Thanks for visiting. Today is about Amlodipine. That is a medication under the brand name Norvasc and some other brand names. Without further ado, let's get all the facts about Amlodipine. These medications can come under different brand names, and the list will include Norvasc, the rest, and even more. By classification, this medication is an antihypertensive agent also dealing with angina, but specifically, it is a dihydropyridine calcium channel blocker. It is already established that amlodipine is a dihydropyridine calcium channel blocker, but there are other members of that family, and that will include nifedipine, nimodipine, felodipine, nisodipine, nicardipine, and istradipine. Now, uses of amlodipine. You are all familiar with the fact that it's helpful in dealing with hypertension. And some individuals will have what is known as isolated systolic hypertension, meaning only the systolic will be high and the diastolic will be within normal range. In such individuals, amlodipine will be a better choice. Also, in princemental angina, that is the old name, now known as vasospastic angina or variant angina, or some will simply define it as coronary artery spasm. Amlodipine will be helpful. In renal phenomena, amlodipine is welcome. Still on uses in pulmonary hypertension, in left ventricular hypertrophy, also in diabetic nephropathy when combined with angiotensin converting enzyme inhibitors or angiotensin receptor blocker. Still on uses, let me quickly touch on this that amlodipine is not for heart rate lowering purpose. No. If you want a calcium channel blocker to deal with arrhythmia, or you just want to lower the heart rate, then go for non-dihydropyridine like verapamil or diltiazem. But if your goal is to lower the blood pressure, improve oxygen supply to muscle, or decrease oxygen use by the heart, come here for amlodipine. Whether it will increase vasodilation and decrease vasoconstriction, not for lowering the heart rate. In organ failure, we have to be very careful, particularly in renal impairment and hepatic impairment. Why that? In renal impairment, because of excretion of this medication and metabolism through the liver will lead us to be cautious and reduce the dose and titrate as it is appropriate. Now, in anyone less than 6 years, you can go for 0.1 milligram per kilogram once daily as the starting dose. It is always once daily. The maximum will be 0.6 milligram per kilogram per day or 5 milligram per day in anyone less than 6 years. But greater than 6 years, yes, 2.5 milligram once daily is welcome, and the maximum dose possible is 10 milligram per day. In adults, yes, you can start with 2.5 milligram once daily, or in some other cases, you can start with 5 milligram once daily. And always know that you must check the blood pressure to help in titrating the dose up or down as it is appropriate. It can be in form of tablet for per oral use. In that case, we find generic at 2.5 milligram, 5 or 10 milligram. Norvasc and other brands will come maybe at 2.5 milligram, 5 milligram or 10 milligram per tablet. For suspension to be used per oral, it can be the generic form at 1 milligram per ml or this brand at 1 milligram per ml. Administration. Nothing so serious about administration here. Just make sure you shake very well, I mean the suspension, and then you take with or without food. Not with grapefruit and not with St. John's wort. Why that? It can lead to inhibition of the metabolism of amlodipine and there will be accumulation of the same in the system. Still on administration, absorption is great when it is taken per oral. The same with bioavailability. It's going to peak around 10 to 12 hours, and the steady state will only be achieved after 1 week up to 2 weeks if the individual is taking it on daily basis. Now, mechanism of action. The effect of this medication will be in smooth muscles and myocardium. And from the name, dihydropyridine calcium channel blockers, right? It's going to block calcium ions influx or entry into slow channels of the voltage sensitive areas, specifically the L-type calcium channels. And what will follow? There'll be decreased level of constriction, more of relaxation of the affected muscles, and then there'll be vasodilation of the coronary vessels, and that will be helpful in angina. There will also be decreased myocardial oxygen demand, and that will be helpful in vasospastic angina as well. And the journey has not ended. The vascular resistance will drop, while the vasodilation in smooth muscles will rise. Then the blood pressure will drop in the face of more vasodilation and less resistance. That is how it will help in lowering the blood pressure. So this is how this medication will help in vasospastic angina and in hypertension, lowering the blood pressure. Now, drug-drug interaction. Those who are familiar with my channel will know that I always leave this to the pharmacist or clinical pharmacologist. But I will touch on this that if you are on these medication, you cannot just take just any antibiotics. Some will affect metabolism of amlodipine. Find out from your pharmacist, clinical pharmacologist, or your physician, please. Also, certain antifungal agents and statins will affect the metabolism. And the list will also include certain apps, or grapefruit juice. So you can't just take St. John's wort or grapefruit juice and some other things that can affect metabolism. So find out from your pharmacist, clinical pharmacologist, or your physician, please. Now, toxicity. In case someone by accident ingests this medication in high dose, there will be profound drop in blood pressure. The heart rate will rise. That will be a reflex tachycardia. And why that? There will be the need to compensate for the profound hypotension. When there is toxicity, how do we treat? Have a fluid generously, and specifically normal saline. EKG should be available and should be continuous. Now, it is ECG, but in North America, it is EKG. Vasopressors at hand and administer as necessary. We'll run into the lab. We'll be battling with renal function test, liver function test, the same with pulmonary functions, and metabolic panning, going for potassium, sodium, chloride ions, glucose, creatinine, and blood urea nitrogen. Now, side effects. Let me state that the side effects that I'll be going through right now is not to say that anyone taking Norvasc will experience all of this. No, no. You might experience one or two or three, and you might not experience any of the following side effects. But truth be told, that it is a possibility that you run into any of the following side effects. Now, that said, heart attack is a possibility. Have that in mind. Then peripheral edema. Peripheral edema will be as a result of certain risk factors. No, just anybody taking it can have peripheral edema, but more if you are taking a very high dose. For example, 10 milligram and above, and you are taking it for a long period, like more than 6 months, more than 1 year, and you are a female. Remember, if you are taking non-dihydropyridines like diazepam or verapamine to handle arrhythmia, you will have less of peripheral edema. But if you have taken any of the dihydropyridines before, like nifedipine, and you are switching over to amlodipine, there's no difference as per the risk of peripheral edema. You can have it at equal level. Then, let me quickly touch on why we have peripheral edema. There will be fluid that will be forced into interstitial space at capillary bed because this medication will lead to vasodilation, and that will increase the arteriolar portion at the capillary bed. Other side effects will include abdominal pain, nausea, flushing, dizziness, fainting, blurred vision, weakness, or itching. Still on side effects, you can have dyspnea, dizziness, diaphoresis, depression or anxiety, hyperglycemia, or epistaxis. Other side effects will include gynecomastia, hypersensitivity reaction, or toxic epidermal necrolysis. You can have insomnia or abnormal dreams. You might have conjunctivitis, interstitial nephritis, or peripheral neuropathy. Others will include malaise, rigor, apostasia, sexual disorders in females, including males with impotency, gingival hypertrophy, hepatitis with jaundice, or osteoarthritis. Again, I'm saying it's not that you must have all this, but it is a possibility. Now, contraindications. Any history of hypersensitivity to amlodipine or any component of its formulation means you are not going to use it today. Then, a noteworthy portion is there could be cross-sensitivity with other dihydropyridines. Let me explain. Someone had taken nifedipine before or nicardipine, and he or she had developed hypersensitivity reaction in the past. Then you are thinking, okay, I'm not going to give nifedipine to this patient today. I'm going to give amlodipine. You are not helping. It's the same. Sensitivity or hypersensitivity to any of the dihydropyridines can lead to cross sensitivity to amlodipine today. Now, part of the contraindications will include we must know the blood pressure before taking this medication. Once the BP is less than 90 millimeters of mercury, no, we are not going to give it. Low BP, no. Hypotension, which is low BP. Cardiogenic shock, will give us low BP. An uncorrected shock of any etiology, I will not give it. Still on contraindications. In pregnancy, it has teratogenic effect. In breastfeeding, it can cross and be in the breast milk, so we will not give it. In severe aortic stenosis, no. Some will give it in less severe aortic stenosis, but be careful. In unstable heart failure, particularly with reduced ejection fraction, then we will not give it. Why that? It can lead to pulmonary edema. In post-myocardial infarction, immediately after post-myocardial infarction, no. One, remember, in cardiogenic shock, I would say in all shock generally, be careful. Don't even give it. With heart failure with reduced ejection fraction, don't give it. High dose can crash that blood pressure. Please be extremely careful. Still on warnings, in severe renal failure, we have to reduce the dose and watch the blood pressure because it is excreted via renal system. And if it's not excreted out and you are giving more and more dose, it will be accumulating in the system. Also, in liver disease, we have to follow the minimal dose for possible shortest period of time. Why that? Metabolism is in the liver, and if it is not metabolized, it will accumulate. Hypertrophic cardiomyopathy, please exercise caution. Still on warning, in neonates or premature neonates or infants, gasping syndrome can occur, particularly if the formulation contains benzoate or benzoic acid. Gasping syndrome is another entity that will be fully explained by me not long from now. Please, in elderly patient, let's start slowly and titrate up if it is required and he or she is tolerating appropriately. Remember that there will be delay in the peak time, mostly in all hypertensive agents. So it will be unwise to be increasing the dose within few days of the onset of its use when it has not peaked. Wait for about 2 weeks to conclude that, okay, the 2.5 milligram that this patient is taking once daily is not bringing the BP down enough before increasing it to 5 milligram. It will take about 1 to 2 weeks before it will peak. Now, in pregnancy, like I said earlier that I will explain further, this agent is teratogenic. It can lead to birth defects. And to the child with less birth defect, the child may be a stillbirth, can be born and not having life. And to those who escape these two and be given birth to, they can die during neonatal period, neonatal death. So don't take that risk in any woman of childbearing age, either pregnant or intending to be. In breastfeeding, it will be present in breast milk. It can lower the BP in that child. Be extremely careful, please. The mother may express the breast milk, but I said not feasible because for how many days? Well, if you think you're going to use it for a short period of time and the mother can express the breast milk and then the child and mother can bond again and be breastfeeding, I don't know how that is feasible. I will not prescribe it to a breastfeeding mother. Better to look for other agents. Monitoring. Well, we'll just keep an eye on the vital signs, the BP, the heart rate, although less effect on the heart rate, respiratory rate, temperature. Then watch out for the peripheral edema and other side effects. And listen to the patient when they are complaining about chest pain. You are using it, to treat angina, but when they are complaining about chest pain, that is heart attack, you better run everything, troponin and everything needed. Improve condition. Is that what we are getting? Are we winning? We want to know. That's part of the monitoring. When it comes to monitoring here, we don't really need laboratory investigation as such. Then the general well-being, because we are dealing with human being, not a piece of paper, not the monograph per se. We need the monograph to guide, but the patient, will tell us better, or we will elicit physical examination will tell us more whether we are winning or not. The BP in particular and other parameters. In conclusion, this is a good medication when taken appropriately, but it could be bad, it could be dangerous, it can kill. Use as prescribed only, please. Don't transfer to anyone. So don't pick the one meant for grandpa or the one meant for your mom or your dad. No, not the one meant for your friend. No two people can be exactly the same. Remember that prescription drugs can also kill. Please remember that. Not only street drugs that can kill you, prescription drugs can kill when used wrongly. With that, I've come to the end of this presentation as per Amlodipine, the brand Norvasc, and others. Please be careful. Only use as been prescribed by a physician. Thanks for listening. Remember to share this, and if you have any confusion, please contact your doctor or pharmacist or both. I appreciate. Share this with everyone on your platform. Thank you.